Good afternoon, and today we have a pleasure of interviewing Dr. Craig Bucks, a doctor of proactive medicine. And we're going to talk about how we can reverse one of the most deadly and common disease of our time. We're going to talk about cardiac disease, cardiovascular disease. And since we all in anticipation of Valentine's Day, well, we around this time talking about the heart going to be very appropriate. Good afternoon, Dr. Bucks.
Good afternoon, Dr. Sokolina.
And thank you very much to our audience. If you have trouble sleeping or sleep next to snoring partner, I personally notice a lot of people who have a trouble sleeping also have a very rich medical history, and cardiovascular disease is one of the things on that medical history. We're talking about high blood pressure or history of stroke or heart attack. And if you're a medical professional who, just like us, trying to put little puzzles of modern disease, including sleep apnea and cardiovascular disease, puzzle of that together and have a whole picture to find the way to help our patients to feel better, be healthy, sleep healthy, feel energetic, then this program is going to be for you. And as just like usual, I share my story of knowing Dr. Bucks. I actually have to thank my friend and mentor, Dr. Carstensen, when I visit him in Seattle, and he talked about new way of practicing, let's call it dental sleep medicine, or I can say also proactive medicine. In his new practice in downtown Seattle, we talk about one of the features, one of the services he's going to offer to his patients for evaluation would be carotid artery ultrasound. And yes, carotid artery is not a dental area, but when we do 3D scan, which a lot of dentists, especially dentists who practice dental sleep medicine, do on a regular basis, you can get the report about calcification in carotid artery. And for me personally, my book Breathless feature the cardiac story of my hero. So that topic and seeing the medical history make me very interested to meet Dr. Bucks and learn what my audience as well as my patient can do to reverse that disease. And I was very impressed with Dr. Bucks' bio. What he's practicing, what he's preaching is actually part of his personal story. He was a doctor of internal medicine, caring for a lot of adults with a chronic disease, how we call them. And those disease, what I see on medical history of my patients every day. We're talking about diabetes, high blood pressure, atherosclerosis. And, he tried to make them respond to better lifestyle choices, supplemental medications. And then all of a sudden, he also suffered from similar things and how he approached his own health. And he was able to reverse, his health to the better outcome, make him change the way he practices, and he's going to share with us, that story. And my first question to you, how dentist and proactive medicine field can be, approached together? That's what Dr. Carstensen will show us in his practice, but I know he's not the only one. We always connect whatever happened in the mouth with systemic disease. We're talking about periodontal disease, sleep apnea, oral infections. How those terms connect to situation with artery or whatever happened inside the arteries, how the opening gets smaller. And we can also call it metabolic disease. It's a broad way how we can describe the disease, but I want to know how you see that connection and why, whatever happened inside the artery really happened.
Well, first of all, I appreciate the opportunity to share this story and on this platform. And I'll start out by saying I'm a little bit prone to punning. You asked a mouthful. There's an awful lot there. When I went to my first Bail preceptorship in 2013, I was shocked to hear from a dentist like what the dentist had to do with all of this. And, you know, I'm a typical Western trained allopathic physician, and I think everything starts and stops with us, and dentists, you know, drill and fill and, you know, teeth. But it turned out that oral health is responsible for up to half of all the events that we encounter as tragedies, you know, either disabling or deadly strokes or heart attacks. And so it really opened my mind. If I have a superpower, it's that I've learned to change my mind. You know, I'm a stubborn German, but to a point. But then when confronted with data, I can change my mind, and I think that's a good thing. We should all need to do more of that. But our healthcare system is not particularly wired for that. So I think dental medicine generally is more proactive than medicine has been, at least in terms of teaching patients through the hygienist, you know, to take better care of their teeth to avoid problems down the road, cannibalizing some future business, you know, when there's clearly more money in, you know, fixing problems than there is in preventing problems. But you guys have always done that philosophically much better than we have done that in healthcare. But I was very excited to learn, you know, that we need to collaborate. And I've been exploring that more and more over the last several years with growing success. It can be tough, you know, to change culture. But at any rate, I'm looking forward to working with more and more of the dental community, because you are the front line in healthcare now. Patients see you more than they see their medical doctors more frequently. They have more trust in you now, and you have a huge opportunity to have some fun. I mean, I don't emphasize that enough, of showing people a problem before it becomes a life-threatening problem. And then, so I call it find and fix and follow. So you find the problem, but now we can also offer a very effective fix, and a very effective and simple and affordable, accessible way to follow it.
I want to ask you, you know, like a general, very philosophical question. What exactly happened inside the arteries? Why heart attack and stroke the most common cause of disability? What happened inside? And I want to bring your slide, and hopefully I can zoom it in.
I can do that from here.
Maybe it's better. Yeah, that's working. I want to, we don't see us maybe, but if you can explain what happened inside the artery, you know, even without us being in the picture. But, you know, that's an artery and how it's getting smaller, the opening of the artery and that plaque actually build up.
Well, one of my mentors once said, you know, I was lamenting that I was struggling to treat a patient because I didn't have a diagnosis. And he said, that's not a problem so much as having the wrong diagnosis. And my point is that we have been so focused on luminal obstruction, and we lose sight of the fact that the real action is in the artery wall. And it's detectable at the earliest stages in the wall, more so than we've ever been able to in the past. So I use the analogy of acne, where acne is an inflammatory condition in the skin that leads to the formation of pimples, and it's pimple rupture or popping, if you will, that leads to an event. And when plaque ruptures, you get a blood clot forming. That's what occludes blood flow and leads to a stroke or a heart attack. This happens very quickly, suddenly, but leading up to that has been a progressive but reversible condition. You'll hear me talk about the fact that we've been using the wrong terminology. The term chronic implies that it's okay to be complacent, that it's not going to get worse if you wait, or that it's not going to get better if you act. And that's not really true. But if we recognize that this is actually a progressive condition that is reversible, and that we can actually measure that progression and reversible results of reversing, then we can accomplish a lot more for the patient.
This is a beautiful thing, and I don't know if I'm gonna remove it from the, oops. So that's what happened inside the arterial wall, and I really like your analogy with acne. So it's growing, growing, growing until it bursts, and then this, you know, let's call it event, tragic event, stroke or heart attack, to the, you know, extent, whatever it happened, and yeah. But what can be done or to reverse whatever happened. I understand what you can check how it's, growing, but what can you offer to the patient? How to measure it, and then the next thing, how to reverse it.
Well, first of all, it's difficult to get people to act with facts and figures and studies, and that's how we tend to present things as clinicians. And one of the things that I've spent a great deal of time learning is that it's important to understand how to sell something, how to sell them. And I used to look at sales as something that was sort of evil that I don't want to do. People should just buy. And when people are having a heart attack or a stroke, they're buying. They don't care. But to convince them to do something proactively is a much more difficult sell. So we have to be persuasive. So we tell stories. It's important to tell my own story and then show. And people are motivated by. Unfortunately, we don't tend to be motivated by opportunity for gain. We get more motivated by that lizard part of our brain that brings in fear, anxiety, and pain and suffering. Fear of loss is much more motivating. So is it possible to go back to the slide?
Yeah, we can bring it back.
Okay. So with ultrasound, we can actually visualize the lumina, the cross-sectional picture of the artery, and see various stages from healthy to early inflammation to plaque formation. And so this is an example of soft plaque. This happens to be a 40-year-old healthy-looking young man who had no idea that he had arterial plaque. This is heterogeneous plaque. This is calcified plaque. Then we can also do the longitudinal view and measure the intima media thickness, which corresponds to this structure here. And we can actually measure it, get a report that measures that, compares the patient's results with other individuals the same age and gender, assign their vascular age, which is the age at which their thickness would be at the 50th percent. And we can actually see improvement over time. And when you show people this, it's like, oh my God, what is that? Well, that's a little bit of arterial disease, which is like having a little bit of cancer. And I just let that soak in for a little bit, because like cancer, we don't want to wait until we're dealing with stage 3 or 4 disease. We want to deal with carcinoma in situ or precancerous, or at worst stage 1 or early stage disease, because that's the best chance for long-term remission. And that's where the term cure comes in. I hesitate to overuse that, but in cancer, if you get a durable remission for 5 years, then you have the patients feel like they're cured. So how do we accomplish this? We deal with the root causes. So
I love this slide about the root causes.
And this I got from the Bale-Dunine method. They've been using this for years. But this is really driven by inflammation. It's not, and just guess where else we find chronic inflammation? In the mouth. Our gingivitis, periodontal disease, endodontal disease, and that chronic inflammation can drive progression of this condition. And in mainstream medicine, we tend to focus primarily on high cholesterol, high blood pressure, smoking cessation, but we ignore a lot of other things up until now. In particular, this big thing here right in the middle that you guys all deal with, and that's about 50%. Well, why are we ignoring that? Well, there's a lot of misery, a lot of suffering, a lot of death and disability with cardiovascular disease, but it's also an industry. And so if you follow the money and you make your living by treating the late stage disease with stents and surgery and rehab and memory care centers and dialysis, the financial incentives just aren't there to replace that with preventive or proactive. And briefly going back to, I use the term proactive medicine to describe what I do, because most people are past the point of prevention. They already have disease. When I do screenings in a population workplace study, about 60 to 70% of the people from all ages and all parts of the organization show evidence of the disease that can be detected and called to their attention. But once you get their attention, then you can have the conversation about what do we do. And it comes down to 3 things, the 3 legs of the stool: lifestyle modification, nutritional deficiency correction, and medication when the risk is exceeded by the benefit. describe the lifestyle modification as I call them the bad S's. Avoid sweets, starches, snacks, sitting, seed oils, stress, salt, smoking, sleep disturbance, and shift work. I might have left one out. And then, but we do use, and then we use, our focus from a treatment point of view is reducing inflammation. One of the most common causes of chronic inflammation is vitamin D deficiency. Homocysteine elevation is a big factor for a lot of people because they don't know their MTHFR status and don't get enough folic acid in their diet. They don't know that they have lipoprotein A, which is treatable and not entirely correctable, but it can be helped. And then the ones I haven't read here are markers that we use to follow inflammation to show improvement.
Those that marker, yes, I would like, maybe I'll bring the on the stage and people can see, but also the good news, as a gift for my audience, Dr. Craig Buck's gonna share his book, and you can find, you know, a lot of information by reading the book, and we're gonna put the website address underneath this interview so you can find and see, you know, the important things. So if you want, I can bring that on stage and you talk about the parameters what you screen to find out the arterial health.
Okay. All right. So the laboratory panel, first of all, there is a history and questionnaire that I have a digital app I call CureCoach.app that enables the patient to provide their information, their background. But really the key thing is to understand these tests. So we check for vitamin D. And our goal for vitamin D is actually higher than you might think. I have some data from my practice now that shows that actually the optimal vitamin D level for arterial health is probably 100.
Mm-hmm.
I used to say 60 to 90, but now I'm shooting for 100 in most patients. These are part of a general panel, but albumin, the ones in red measure various aspects of inflammation. Everybody knows about C-reactive protein, but it's probably the least helpful, frankly. The ones that are really helpful, the one I stare at the most is the LPPLA2, which is reflective of activity in the artery wall at the plaque formation, and then myeloperoxidase indicates the risk of plaque rupture. Myeloperoxidase rise triggers me to say, go see your dentist and make sure you don't have an asymptomatic infected root canal that can only be picked up on cone beam CT. We picked up a number of those. And
I did too, and I was really shocked, you know, because you have to really look so carefully for those, you know, it's not it's really, you have to look. I totally agree with you. I have to be a Sherlock Holmes when I do the reports like that for functional medicine doctors.
Right. So now in my practice, I do salivary testing, but I don't do endodontal, I don't do treatment. I try to get their dentists and hygienists to pay attention to the high risk microbiome. And if they don't, then I offer them a connection to a resource in our community that is on board and pays attention to these things more carefully.
That's a lot of education. But I want to share with my audience, once patient, you know, diagnosed and with all this, you know, with all this data, so they know this, you know, you saw it on the scan, and there's a thickening of arterial wall, and you saw it on a blood work, you know, all the elevation of this data. What happened next?
So then I put together, I call it a plan, a cure plan, like a game plan. So I use a sporty analogy. My role, I believe, is primarily that of a coach. You know, the patient has to participate and play and ultimately receive their outcomes. But we're going to keep score as we go along. We're going to keep track of the data. We're going to measure. You improve what you measure. If you don't measure it, it's not going to improve. So I meet with them typically either in person or by Zoom. The only thing that I really can't do by Zoom is, you know, this step where they use the ultrasound probe, but that's the reason I'm trying to get them, make access available in the dental practice because patients are already going there. We can then meet digitally or in person. The labs are drawn. I use Quest Diagnostics. They have patient service centers all over the country. And then we meet and go over that report. and put together a plan. I have a checklist. My clinic note is a checklist. The patient gets a copy of the clinic note afterward. When we do Zoom meetings, I actually record the Zoom meeting and I send them a copy of a link to the recording so they can go over it again. And then we also ask them to read our book, which is, the book I wrote is more of a booklet. I call it an owner's manual for people with arterial disease, or an instruction manual. If you're looking for an encyclopedia or a textbook, it's not your thing. It's only 88 pages. Recently, we did a Speechify modification with it, so you can listen to it if you prefer. Point is, just get to the point. What are the things that mean the most? Because we have a short attention span these days. So we try to meet each patient where they are. We put together the plan. We, supplements to fix deficiencies, and then typically at about a 3-month interval, we repeat the labs that we expect to change and meet again. When we make adjustments in the game plan, so it's like a quarterly huddle. I call it a huddle. And then we go back and we play the game for the next 3 months, follow up labs. And typically that's when I'll say, let's see if we see any improvement in your arterial age, because it takes 3 to 6 months for that to be seen. The laboratory information is like you're driving down the road, what you see in front of you, the road conditions, the traffic, the weather, the instruments. The ultrasound is like looking in the rearview mirror for the last 3 to 6 months. Where have you been? Or if you want to use your stock or your investment portfolio, what's the market doing today versus what did it do the last quarter? And both are important pieces of information, but you can do a lot even if you don't have everything. It's ideal to have all that together. And what typically happens is if we see that improvement, then you have the patient. You've shown them improvement. Okay, now we're benefiting, and you see the other way to look at that graph, that picture of the artery, is that's kind of like their lifeline. How far are you on your lifeline? And I think this is important regardless of age or where they are, if they've already had an event, because it's always reversible. Earlier the better, but early on we're trying to prevent premature deaths and widows and orphans. 60s, 70s, we're trying to prevent strokes and disabling, so people lose their fortune to a nursing home or rehab center. And then even later in life, I have patients in their 90s who are still doing this because it keeps arterial disease as a major contributor to dementia. Absolutely. And the things that we improve, particularly metabolic disease, mainly metabolic syndrome and insulin resistance, which I think is the number one thing that we should be paying attention to. It's getting better. We should take our eyes somewhat off of LDL and focus more on sugar, the bad S's, the sweet starches, snacks.
That's very promising. And I actually, it's eye-opening. My grandma died when my father was 17. So he lost his mom in such an early age, and she was a doctor from heart attack. So that was, devastating. I never had a chance to meet my grandma. And now thinking about that, what can be totally preventable with the modern knowledge.
Yeah, one of the questions that always bugs me is why don't more people, avail themselves when they're told that this is an opportunity? It's like, pun intended, like pulling teeth to get people to act. And I think it's because as a society, we've been brainwashed for many, many years, for decades, that there's, if you have a heart attack or a stroke, you can call an ambulance and they can get you to a hospital and they can rescue you and you can be fixed. And that sometimes is true, and we've gotten much better at that. However, when seconds count, the ambulance will be here in minutes. The door to balloon time is 90 minutes for a angioplasty. That's just not good enough. And preventing the event by being proactive about the progressive condition that's leading up to the event is really the answer. And again, reinforce that you wouldn't sit on stage 1 cancer and wait for it to get worse. The other one I use, I have to be a little careful about this, but being a little bit pregnant, you don't expect that to at
to
some
go away.
point you have to come to deal with it, embrace it and move on for the best possible outcome.
But you know, doing the program like ours, like whatever we're doing now, we're educating people, because even for me, thank you very much. I have a very close friend who is a cardiologist, Dr. Regina Drus. She was on my program, and I learned about this proactive medicine and all these functional aspects. And now, thanks to you, now I know that, but I'm sure not a lot of people have those knowledge. So we really appreciate your time. And I hope for our audience, if you have any questions, you get in touch with Dr. Box, and he's so generously offering his book and Discovery Zoom. You'll find all the information underneath the interview. And thank you very much for bringing us our healthy hearts and healthy arteries. Thank you.
You're welcome. I look forward to it. Thank you very much.